So over 4 years, so this is following people over time, so over 4 years the average gain in weight was about 3.5 pounds. And the energy imbalance between what you eat, what you take in, and what you expend, the imbalance only needed to be between 50 and 100 calories per day to actually have this gain in weight, which is not very much at all, considering that the average adult eats about 1,500 calories a day for a recommended calorie intake. They did what's called a regression analysis. So what they did was they took variables and they put various foods and various behaviours in and out of this model to see how much that contributed to either the weight gain or the weight loss. And you can see from some of the common foods that are readily available nowadays, particularly some of my firm favourites, which are potatoes. They don't fare very well at all, with about 1.3 to 1.7 pounds of increase. Sweetened drinks, vegetables and fruits, we knew that already, they're our best friends. But I'm not a nutritionist, I'm a physiotherapist, so if you do like the potato chips, then you also need to get physically active to negate that energy intake. Another interesting one, thinking about a holistic approach, is sleep. So if you sleep less than 6 hours or more than 8 hours, that was also an independent predictor of gaining weight. And there we have the sedentary behaviour again, which is TV watching, which was 0.3 pounds per hour per day. So another excuse to get off of the couch. So the American Heart Organization last year in 2013 now define obesity as a disease. And this has caused, there's quite polar views if you have a look on the internet about whether obesity should be a disease. But throughout the rest of the presentation, we'll be having a look at some of the factors that actually make people obese. So this is an example of the international classification for function, which as physiotherapists, we use this to clinically reason the management of patients. So to quickly have a look through those headings, a health condition, which is at the top, it is another word for a disease. So a body function is body structure and function, which in old language was an impairment. In the middle we have activity. The old language used to be disability. Participation, going across to the right, is handicap. And then we have environmental and personal factors, which can also impact on the health condition or disease. So if we think about people that are obese in physiotherapy, how does it impact on physiotherapy? So are we doing our job? Are patients achieving their rehab goals? Are they maintaining their function? So if we have a look at some common conditions which are associated with obesity, which is osteoarthritis and diabetes, because they're independent risk factors along with obesity for non-communicable diseases. Some patients will find if they have osteoarthritis that they can't actually go for a total knee replacement because they're too heavy. So they're told to go away, lose weight before they come back and have an operation. And likewise with bariatric surgery, which is now a treatment option for the management of diabetes and the weight itself. Again, to be eligible for surgery, patients have to be a certain weight. So there's no avoiding the weight issue. So to complete this, this model, to actually know what's limiting activity in people that are obese, myself and Sylvester Dengzee, who was an MSc student on the physiotherapy course, completed a systematic review. So with a systematic review, the whole point of the systematic review is to make sure that you have all available research to answer your research question. So we were interested in what barriers there are to physical activity in people who are overweight or obese. So we did comprehensive searches and retrieved a lot of references. We screened the titles and abstracts, then we screened the papers, and we found 5 that actually met our inclusion criteria, which were about barriers for physical activity in overweight, obese persons. And these are some of the barriers that people in the papers reported. So on the biological side, a lot reported physical discomfort whilst being active or exercising, and so fatigue or shortness of breath, which they perceived to be harmful. The comorbidities that they also had along with obesity, such as diabetes or osteoarthritis, they also impact on their activity levels. So here is a quote from a lady who has diabetes for 17 years, has osteoarthritis of the spine, and she's saying how she used to walk for 15 minutes twice a day and lost lots of weight, and then she must have put the weight back on again because then she lost 35 pounds, but she's saying that she can't do it anymore because her blood pressure spikes. So the patients themselves are acknowledging that other conditions can actually be a barrier for activity. And then there's also the weight itself. So again, people realise that the more physically active they are, the more weight they lose, and vice versa. Then from a psychological point of view, there's the body image factors. People would prefer to exercise by themselves because they don't want to be around skinny minis or people that are small. Because they're repeatedly trying to lose weight and regaining the weight, this results in a lack of control or a decrease in self-efficacy, because it takes ages to see results and lose the weight, so they give up before it's successful. Another psychological factor is also depression and self-esteem, which is another condition which was associated with diabetes. And finally, there are social barriers, so accessibility to leisure centre, support, so exercising or being active with another a friend or colleague, and the distance from a centre. It's very interesting that they focus on leisure time activity, and they don't think about activity that you can do at work or even in the household. They all count towards your physical activity levels. So if we have a look at and try and complete that ICF model, we can see now the picture's a bit more complete. So as a physiotherapist, these are the things that I would be looking out for, and so repeat attempts at trying to lose weight, shortness of breath or fatigue on fitness or exercise testing, their accessibility to leisure centres are things that all I would assess with a person that was actually trying to lose weight. So these are factors that patients or participants will say that are barriers to activity. But what about people who are actually successful in being active for a year? Are they different from people that are inactive and not successful? So this is another systematic review that myself and Sylvester have been completed for his summer studentship over this summer in 2014. The results are very much preliminary. We're halfway through the systematic review, but there are some interesting things that are coming up out of the research. And like the barriers research, people are saying that they prefer to exercise at home versus in a group. They're twice as likely to adhere to the exercise program. If they have less weight to lose at baseline, they're more likely to adhere. If they're less stressed or less fearful, they're more likely to adhere. If they have a higher fitness level at baseline. Interestingly, a lower educational level, which goes against what you might think. And being married without children, so not having children commitments, also predicts adherence. But we also need an air of humility. Even with all these factors, we can expect 50% success rate after about a year. So hence the old adage, you can help some of the people some of the time. So some take-home messages. So physical inactivity is an international health issue and is causing numerous conditions. Our natural tendency from our lifestyle is to gain weight if we partake in certain behaviours. It only takes an imbalance of about 50 to 100 calories a day of intake versus expenditure. and the barriers to physical activity and their predictors of adherence have many similarities. So when we're designing programs for patients who do wish to lose weight and get active, we should take these into consideration. Thank you very much.
Thank you. Thank you very much.